Okay, let's just start. Hi, everyone. Welcome to our today's program. After a long break, I think about 1.5 months later, we are now back to our pavilion with again our ultrasound cases webinar on Friday. Unfortunately, we are not getting much response about these webinars. For last few months, we tried to convince people that these webinars may be helpful for people, but we didn't get much response as like we got for our YouTube videos. Usually the videos had a very good amount of response, but for the live sessions or when we upload this video to our YouTube channel, we usually don't get much response. So hopefully we are getting back to our daily case series, which will be uploaded in our YouTube channel. So don't forget to subscribe our YouTube channel if you are new here. So anyway, today we are going to talk about 5 ultrasound cases like before. If you haven't seen our previous sessions, we have a YouTube channel named Imaging Study, which has got fortunately around 68K plus subscribers. So we have uploaded all our previous ultrasound cases video series in our YouTube channel. So you can just go search on the YouTube writing imaging study, and you can see all those videos free definitely. And also we have got many other videos which may be helpful for you. So don't forget to check them, and don't forget to subscribe our YouTube channel, because next time we hopefully are going to upload our videos only on the YouTube channel. So let's jump into our today's first case. If you're new to our program, please just don't forget to share your location from where you are just watching this content in our comment box. I'm just checking the live just beside me. And yeah, if you have any question regarding any cases or whatever, you can just put that down below so we can just go and check that when the session ends. So anyway, let's jump into the case number 1. This will be a very simple case. This is a 27-year-old male patient who came with no definite such a history. He just came for a routine abdominal examination. I think he came just before going abroad for work or whatever like that. So anyway, let's jump into the case. So during our examination, ignore the measurement technique. During our examination on the right side, we saw the liver is quite okay, but there was no right kidney. So we searched for the right kidney in our common abnormal locations like the pelvic region, iliac fossa, whatever. But we couldn't find the right kidney. So don't waste your time looking for kidneys. You just go to the left side and see whether the left kidney is enlarged or whatever the abnormality is present there. So we jumped into the left side, and now this is the left kidney. It doesn't look quite normal. It's quite enlarged, and if you look somehow this is the renal cortex. It ends up here, and this is a gap, and there is another renal cortex, sorry, the renal sinus at this part. So there are 2 separate pelvic-calyceal systems. Now it may be a duplex kidney on the left side. That is not very uncommon, but you haven't seen the right kidney on the normal location, so you have to think more deeper. Now, if we freeze the image at this point, go a little back, now you can see, and there is a dimple over here. So it indicates that this is one kidney and this is another kidney. So there is a junction between 2 kidneys, or you may say that 2 kidneys are fused together. So this is the left kidney, this is the normal left kidney, and the right kidney, which is not seen on its normal location, is connected or fused to the lower pole of the left kidney. So this is called the cross-fused renal ectopia. Now, when we try to report the cross-fused renal ectopia, we make some confusions like, is it cross-fused left renal ectopia or cross-fused right renal ectopia? Like, the right kidney is fused to the left kidney. So the right kidney is located on the left. So will we say the left-sided cross-fused ectopia or whatever? Look, that's very simple. You're looking at an ectopic kidney. Which one is ectopic, right or left? The right one. We didn't see the right kidney on its normal location. So this is an ectopic right kidney, which is fused to the left one. So we will call it cross-fused right renal ectopia. So this is a right renal cross-fused ectopia. Okay, so it makes some confusion sometimes when we try to report whatever. So here is another view. Now you can see this is the right kidney and this is the left one, which is fused with the left kidney. Now, if you look at the sinus of the right one, now you can see this. There is a slight pelvic system dilatation, or sometimes it may be an extrarenal pelvis in some situation. And whatever it is, you can see the pelvis is directed anteriorly. So it is very common to have a mal-rotated right one because the normal pelvis should be directed posteriorly, the posterior medially or whatever, but this is directed anteriorly. So there is always a possibility of obstruction or the hydronephrosis for the fused one. So here's the right one and here's the left one. There is a normal renal parenchyma at the mid part separating two renal sinuses or the pelvic systems, whatever you say. And the pelvis of the right one, which is fused to the left one, is mildly dilated and directed anteriorly. So this is a case of right renal cross-fused ectopia or right renal cross-fused ectopic kidney or whatever you want to say. So the left kidney is located in its normal location, but the right one is fused to the lower pole of the left kidney, and make sure they do not cross the spine. If they cross the spine, we go for the horseshoe kidney, which is obviously a common finding in our clinical practice. And both looks quite normal without any parenchymal destruction or thinning. And the right kidney, which is fused to the left one, has a mildly dilated pelvic system with the pelvis directed anteriorly, which is a common finding. Okay, so let's jump into the case number 2. This will be a 48-year-old male patient. And yeah, there is a right knee swelling at the posterolateral aspect. So the clinician sent us the patient for excluding the popliteal fossa cyst, which is known as the Becker cyst. But the lesion is quite firm. So the clinician wants to know whether it's a Becker cyst or it's any other lesion, because the location is quite different, because the popliteal fossa cysts are at the medial part or the posterior part, but this is quite laterally placed structure. So let's jump into the case. It will be very easy. So here's the picture. We are at the posterolateral aspect or the lateral aspect of the right knee. Now you can see a macellation over here, and this macellation has a tapered end. If you go superiorly, you can see a tubular hypoechoic structure which is connected to this macellation. So that makes the diagnosis very easy diagnosis. So let's look at the mass a little deeper. So here's the inferior end, and on the inferior end of the mass, you still can see this tapered end, and there is another tubular structure connected to this lesion. So the lesion is round or oval in shape. It has a heterogeneously hypoechoic texture. You can see some cystic spaces, which should be blood vessel or necrotic spaces. The necrotic spaces are quite common in such case. So there is no surrounding architectural distortion. So what it can be? So we are at the lateral, posterolateral aspect of the knee joint. This is the very common location for the common peroneal nerve, and you are seeing a thick common peroneal nerve at the superior aspect, and you can see the nerve also at the inferior aspect, and both ends are actually connected to this common peroneal nerve. So this is nothing but a peripheral nerve sheath tumor of the common peroneal nerve. So here's the location. You can see the lateral aspect. The common peroneal nerve goes just side to the fibular head. So this is a very common area for the nerve sheath tumor of the common peroneal nerve. So this tapered end and communication with the hypoechoic linear nerve is a very important feature to make the diagnosis quite easy. Now we want to put some Doppler to see the vascularity. Sometimes the nerve sheath tumors are highly vascular, sometimes they are not very vascular. So in my case, you can see there is no severe vascularity, only some peripheral vascularity. And these cystic spaces we saw before have no vascularity inside. So they're just some necrotic spaces. So when a lesion gets enlarged, it's very common to have some cystic or necrotic spaces inside. So this is nothing but a case of nerve sheath tumor. So here is the upper end and here's the lower end, and you can see this common peroneal nerve. It is quite thickened at this point and getting connected to the peripheral nerve sheath tumor. So we put some 3D because we don't have much work to do. So we have some relax time and we just put some 3D, and you can see a testis-like appearance of this nerve sheath tumor. Don't just misdiagnose it as an ectopic testis at the knee joint. Okay, so we put some tomographic ultrasound imaging. We are actually trying to make a good view of the nerve ends connected to the nerve sheath tumor. But this view may not be very satisfactory for that. But you can see some cystic spaces quite well understandable in these pictures. Now, we have chosen the multiplanar imaging. Here you can just choose the area, choose the line to see it on a 3D image. So we tried to take a picture and try to draw a line through the nerve ends. Now you can see a glimpse of the common peroneal nerve, which is getting connected to this mass lesion. So whenever you get a good large lesion, just try to practice some 3D over those lesions so that you can just make better quality pictures in future. So anyway, this is a case of peripheral nerve sheath tumor of right common peroneal nerve. We can see that this palpable swelling at the posterolateral aspect of the right knee is showing an ovoid heterogeneously hypoechoic mass with some internal cystic spaces, tapered ends, which is connected to the common peroneal nerve, and there is no prominent internal vascularity. Rather, we are seeing some peripherally placed vascularity. So this is a very common finding we get in many places of the body, and yeah, this is very common. So let's jump into the case number 3. This will be a 6-year-old boy. Um, he gave an interesting history. The patient's mother said that they can palpate testes sometimes, and they usually don't see testes sometimes in the scrotum. So during examination, the clinician said that we saw the prescription. The clinician have described that there is palpable testis within the scrotal cavity. So let's see what we have got on ultrasound. Here we have put ultrasound, the linear high frequency transducer using. We are seeing the inguinal canal. So during our examination, we can see testes on the right and on the left. Both are placed in the mid-inguinal canal. So these are bilateral undescended testes. Now make sure your clinician has written that he had palpated all two testes within the scrotal cavity. So now what's going on here? We can see easily, we can visualize these testes within the inguinal canal. So here you can see we have tried to measure the testes. This is quite normal in size for this age. So we are not making any bad comment regarding this. So let's see the testis again. So we tried to check the testis, and we saw that the inguinal canals are empty. So what happened? Now we check the scrotum. Now you can see both testes are located within the scrotum. That happened just within a minute. So yeah, we can see both testes within the scrotum, but we just a minute before we saw both testes within the inguinal cavity, inguinal canal. So what actually happened here? So we are a little bit confused. Just let me just delete a comment. Okay. So now let's see the testis. You see the testis is moving within the inguinal canal. Oh, you can see a very good movement of the testis. We are not doing any maneuver or whatever, but with the contraction, the testis is automatically, we are just putting some cold gel so that with contraction, the testis is going upward. So this is a very mobile testis, and we call it a retractile testis. So here you can see during your examination, this is another one, the left. Oh, yeah, the testis went downwards. So this is the retractile testis. So they sometimes live in the inguinal canal, sometimes they want to live in the scrotal cavity. So again, another view, and now you look at the testis on transverse section, you see they're moving, they're just going out from our view. So this is called the retractile testis. Okay, so this was a case of bilateral retractile testes. During our examination, the testes were seen in mid-inguinal canals, and after a certain time, they went downward to the scrotal cavities and again came back to the inguinal canal. So usually this situation is surgically corrected because when the testes are within the inguinal canal, it's not a good place to have a better environment. And due to this high temperature, it will definitely get some problem. So we just want to correct this situation surgically. Okay, so now let's jump into the case number 4. Case 4 and 5 will be a little bigger one. So this is a 30-year-old female patient who came with severe upper abdominal pain, and there was a history of fever, not at this moment, but there was a history of fever around a week ago. So let's see what we have got on ultrasound. Here you can see the spleen. This is a spleen. There is no history of trauma. Trust me, there is no trauma history. So you can see that spleen is not normal, obviously. You can see some cystic spaces. You can see the maintained capsule, and the size was quite normal. It was around 11 centimeter or whatever. But you can see the internal parenchyma is completely distracted. If you look at the remaining parenchyma, you can see some echogenic lines. These echogenic lines are called the bright band sign. You have heard about this terminology. Let's look at another view. So here you can see again this echogenic linear stripes, which are called the bright band signs, and you can see some anechoic spaces within. So this bright band sign is a very definitive feature for the infarct. But this is not a single or a segmental infarct. You can see the whole spleen looks similar with some liquefaction or necrotic change. So we want to see the vessels right now. We want to see whether there is flow within the splenic artery or splenic vein or both. So let's put some Doppler. So on color Doppler, you can see there is no parenchymal vascularity. You can see some artifacts. You can see some glimpse of adjacent vessels because this is the area for stomach. So you will see some surrounding stomach gastric vessels, renal vessels, and so many things. But you can't see the splenic vessels entering and getting out of the splenic hilum. So this is actually the global infarct of the spleen. What is the cause? So you can see there is another view and there is no internal vascularity. Sometimes you may see some vessels, but these are actually the renal vessels overlapping the view. So make sure you are not looking at the splenic vessels. So again, another view, we are just trying to ensure whether there is some vascularity, but yeah, we are not expecting to see some vascularity in such distracted situation. So yeah, this is a very uncommon case for my community. So let's put some Doppler spectrum. So we took some vessel, we saw some vessel and we took some sample, but there is no apparent vascularity here. So these are just some moving pulse from other vessels surrounding the spleen. Okay, so there is no parenchymal vascularity. So we traced the splenic vein and artery. We couldn't find any splenic arterial flow at the distal part where it is entering into the spleen, definitely. But we traced the splenic vein, and this is the pancreas. You can see posterior to the pancreas, this is the splenic vein, and you can see there is no vascularity inside. You can see some hypoechoic content inside, which is the splenic vein thrombosis. Okay, you can see some flow here. This is the flow from the supramesenteric vein, which is entering into the portal vein, but the portal vein is not getting flow from the splenic vein. We checked the portal vein, that was quite normal. So this is definitely a splenic vein thrombosis going on here. So there is no flow within the splenic artery, no flow within the splenic vein. That is very unusual situation going on here. So this is the splenic vein thrombosis showing no flow inside. It is not collapsed. You can see the vein, but there is a hypoechoic content inside. That is the thrombus. So we checked the surrounding area. There was mild hepatomegaly or whatever. This is not showing in this picture. We found some peripancreatic lymph nodes which are enlarged. You can see the measurement here. And we can see some gallbladder wall thickening. These are the reactionary features. So this was a case of splenic infarction causing severe parenchymal destruction, areas of liquefying necrosis, with a no flow within the splenic artery and obviously the thrombosis of the splenic vein. Now, we want to know the cause of this case. If you're from my country, um, you know that just few months ago, we had some regulations or some limitations or some precautions for some travel procedure. So the patient was a Muslim patient and she gave us a history of Umrah, for we go for the Umrah procedure or Hajj procedure in Saudi Arabia. So before going there, there is a very important precautions we need to take. We need to take meningococcal vaccination. And this patient had no history of meningococcal vaccination. She made some false papers and just went for Umrah in the month of February or something like that. And after getting back from Umrah, she had bad fever. We've got some cases in our country who even went to intensive care unit and died spontaneously. So this patient fortunately didn't die, but she had a bad fever, and after that when she came to us, we found this situation. So this is actually the post meningococcal splenic infarction. So make sure if you find any patient coming back from Middle East with no history of meningococcal vaccination and gave history of a fever, then you see this splenic infarction, make sure to search for the post meningococcal causes. So this is a post meningococcal splenic infection. Okay, so it was not diagnosed. Okay, so let's jump into the case number 5. I was very confused about this case first because how she actually made this such infarction, but she gave a very good history of going to Middle East just a few months ago. Okay, so let's jump into, we are not very familiar with the meningococcal infection. It is not a routine infection for the young female patient of 30 years. We have fevers like dengue fever, chikungunya, or whatever going on here. But it is quite uncommon, and if the patient didn't give a good history of traveling, it would be very difficult for us. Okay, so um, anyway, let's jump into the case number 5. This will be definitely the obstetric one, and this is a 20-year-old female patient who came with 5 months of amenorrhea. There was history of previous scan showing some abnormalities, so the patient was sent for further evaluation. So I really hate the referred cases because they are not usually comfortable. So just start the case with the measurement. When we try to measure the biparietal diameter or abdominal circumference, we failed. You can see this is the condition of the head. Now you can understand what you are going to see during the head examination. Okay, so ignore that. We had a good posterior placenta, and we measured the femoral length. So femoral length says that this is around 22 weeks of pregnancy. Okay, that's good. So let's jump into the head now. So here's the head. You can see the brain matter. These are deformed brain matter outside the cranial vault. So we are going to see an exencephaly. Okay, so here's the cranial vault absence. You can see the orbits, you can see some frog-like appearance, but there is no nasal bone here. And the above the above the orbits, you can see the brain matters are outside the cranial vault. So we call it the exencephaly. If we dissolve this brain tissue, we'll go for the anencephaly. Okay, so that's okay. This is exencephaly and anencephaly, but we are not still ending this session here. So let's see the case. You can see the cranial vault is absent, the brain matter is outside, but there is something else here. If if you look at the abdominal part, you can see something is out of the abdomen. So we want to evaluate more and more in this case. We have so many videos of this case. So here you can see this is the placenta. You can see this structure from the fetal abdomen coming outside. This should be the liver. So you can see some vessels. You can see the portal vessels here. So this is the liver actually, which is outside the abdomen. So when it is outside the abdomen, we call it gastroschisis, omphalocele. If it is covered with the membrane and umbilical cord inserts into it, that we call it omphalocele. Otherwise, it will be gastroschisis. So in such case, we are actually thinking about gastroschisis because here you can see some intestinal loops here. So everything is outside the abdomen. What is going on? Now, just let me freeze the image in the middle part. You see, this is the placenta. You see, this is the fetal liver. There is no gap between the fetal liver and the placenta. So they're fused together. We need to evaluate this carefully. If there is no gap, there is no movement at this part, we are going to make a very bad diagnosis. So the mortality rate will be 100%. Okay, so we want to see that. So here you can see the abdomen. It's a very disgusting case for us during a very busy practice, but this is very important for the patient to make the complete diagnosis. Here you can see the brain outside, and let me just freeze the image here. Just go here. You can see this is the liver, which is connected to the placenta. Yeah, it is connected to the placenta at this part. So when the liver is connected to the placenta, we call it the body stalk anomaly, which has got 100% mortality rate because you can't deliver it with a normal condition, definitely. So the body parts of the fetus is connected to the adjacent or attached to the adjacent placenta. That's why they are outside the abdomen. So it's a very notorious case. So in such case, we expect spinal problem, we expect heart problem, we expect limb problem. So you need to search all of them right now. So let's look at here. You can see this is the liver outside the abdomen. Umbilical cord is not inserting into this part. It is inserting laterally and entering into the abdomen. And you can see the heart is pumping, and this liver is connected to the placenta, which goes in favor of body stalk anomaly. Very disgusting thing. If you look at this part, you can see the glimpse of the spine, and that should not be normal also. So we put some Doppler, you can see the cardiac pulsation, you can see the placental vessels and hepatic vessels, they're both connected. So this vessel, placental vessel, is entering into the abdomen or connected each other. So this is not a good sign. Definitely it is the invasion, or this is the connection between the liver and the placenta. So here's the view of the urinary bladder. We're trying to see whether there is a single umbilical cord artery or both. You can see two internal iliac arteries beside the urinary bladder. So umbilical cord artery should be normal. But here you are seeing the part pumping. You are seeing the liver showing internal vessels. So the liver is connected to the placenta. So yeah, this is the communication. Now, if you look at the surrounding area, we want to see, oh, let me freeze the image here. You see the limb? You see this is the tibia fibula here. Just look at the foot here. Just let me move the probe a little bit. You can see this is one foot, and yeah, this one is another. So you see, this is the tibia coming here, and this is the foot, which is upwards and attached to the, this part of the foot is attached to the tibia, or this is thus bended or extended to the tibia. So this is actually the club foot. So here you can see the, this is the clubbing. So the foot is going upwards. Yeah, we expected that. The another foot is also showing this. Yeah, the another foot is also showing the same pattern, but yeah, it's definitely very difficult to understand in such situation. So yeah, this is the foot abnormality. So both feet are showing clubbing. Okay, so yeah, this is the clubbing here. You see the foot here that is going upwards, and this is another feet over here, which also showing the similar feature. Okay, so let's look at the other parts, and yeah, liver is connected here. You can see the intestinal loops over there, and yeah, we tried to search for the hand abnormality, but due to this such position, it was not possible quite. But we expect some hand abnormality, obviously. So yeah, we are going a little bit forward. Now, if we look at the surrounding area, we are just focusing to trying to see more and more abnormality. The umbilical cord is inserting in this position, not at the central part, it is eccentric. So it is inserting into the lateral part, slightly lateral part. Okay, so we tried to check the spine. So, it doesn't look quite normal. So this is the upper part of the mouth area, or yeah, the facial area. We can't see the nasal bone over here, you know. Just let me freeze the image for a while. Yeah, we're expecting to have a nasal bone at this part. We're not quite sure about this one because this is the area where it should be. So we are not satisfied with the nasal bone also. So we are trying to search for the nasal area, but we are not satisfied with the nasal bone. So again, we are trying to see the spine. We are not satisfied with the spine. You see, this is the area where the spine is somehow showing some scoliosis. We are expecting to have some spinal abnormality, but it's very difficult to evaluate and differentiate whether there is a normal lumbar region or normal cervical region. So we just want to stop it as a spinal dysraphism. This is a perfect case for fetal MRI, but not for the ultrasound because the lower part is not well understandable. Okay, so we are just trying to see the spine. It's a little bit difficult to understand, definitely. So let's jump into the fetal heart now. So here you can see the fetal heart is pumping, but due to the position condition, it will be very difficult. But we tried our best to make the diagnosis. We are expecting to find some abnormalities. Let me freeze the image. Maybe it's not very good image, but it may be helpful to understand that there is a ventricular septal defect at this point. Yeah, definitely it's not the best picture, but you should expect a ventricular septal defect in this patient. So there is the, here you can see the blue colored, the left ventricular outflow, and there was a ventricular septal defect at this point. So this is the ventricular septal defect. We expect to find this feature here. So yeah, overall, this was a very complex case. And now you can see the liver is connected. During our whole examination, there was no separation of the liver. Rather, it is connected to the placenta at this point. So yeah, this is a case of body stalk anomaly with so many features here to end the diagnosis. So here's the clubbing. You can see the foot is upwards in direction. So this is another foot, and still there is a problem here. Okay, so yeah, the brain is outside the cranial vault, and you can see the heart here pumping. So overall, the mortality rate in this patient is definitely 100%. So there was gastroschisis. You can see the intestinal loops, and you can see the liver is attached to the placenta. So here's the high frequency view, and you can see the liver, part of liver is attached to the placenta at this point. So this is a 21 to 22 weeks of single live intermittent pregnancy with cephalic presentation and adequate liquor still at present. We couldn't see the kidney or differentiate quite well, maybe due to its position, but we expect to get oligohydramnios very soon. But still, we have found the urinary bladder, so we expect to have a good situation or position or function of the kidney till now. So there was a body stalk anomaly showing the attachment of the fetal liver to the placenta. There was gastroschisis and exencephaly, absence of nasal bone, ventricular septal defect, spinal dysraphism, which is not clear how many spinal problems are there. And obviously there was bilateral Clubfeet. So this is a long case, and yeah, the prognosis is 100% death. So thank you for joining me for such a long session today. And hopefully we are going to upload our daily case series on our YouTube channel. So don't forget to subscribe our YouTube channel. If you're from my local country, we have a paid session tomorrow about the fetal central nervous system abnormalities. I have taken this session many times in the last 2 years. So if you are interested, you can just join there. It will be not a good session because the central nervous system abnormalities are not very comfortable to me and to you also. If you're from our radiology background and you're a radiologist or resident watching this session, we have a masterclass on imaging in obstetrics, which is a very excellent topic, I think, and very high demanding topic on the 12th September. That means next Friday. So I will be very busy at that day. And we have got almost anything that you want about the imaging in obstetrics in our this program. So don't forget to register for this session. This is only limited to the radiologists and radiology residents and trainees. So just try to communicate or contact in your department for the registration process. Yeah, we have very interesting topics, and I think if I'm not wrong, I have some session there also. So if you're from the ultrasound background or radiology background or nuclear medicine background, the Bangladesh Society of Ultrasonography is going to arrange our national conference and workshop on 24 and 25th October 2025. So if you are interested, you can join there. If you are interested, you can also just present your paper there. So we are expecting to present 30 papers in this session. So if you have any interesting case, don't forget to share with the country and the world. So we highly suggest you to make an abstract. Just make an abstract, and if you want, you can just send me. I can just edit that for you, and so that you can just present that in this program. Okay, so that will be interesting. And the registration process is on, so you can just contact to the Bangladesh Society of Ultrasonography office in Eastern Plaza in Dhaka, or you can just send them payment to the given numbers and contact with the authority. So the registration fees are different for the conference day and for the workshop. And we are going to have Susan Campbell from Australia, which she's very popular for ISOG and everything related to obstetric imaging. So don't miss this program, obviously. So our next paid sessions will be given, or the notice will be found in our imagingstudy.com website. So if you're from my local country, you can just go and register from our website. So if you are new to our program, we have Imaging Study, a YouTube channel, which has already got 68K plus subscribers, around 69K. So we are going to upload some cases here routinely, I think, as like we did before. And also this video will be uploaded in our YouTube channel tomorrow. So you can just go and get that also there. So don't forget to subscribe, because why not? Yeah, thank you for joining me today. If you have any question, you can just put that down below. So yeah, for the foreigners, we don't have the payment options still available. So that's why we are not encouraging them. And also our this session will be in local language, so it won't be very comfortable for the foreigners. And yeah. So if you have any question, you can just ask me here or in our Facebook Live. Okay, sorry. Uh, Okay, so anyway, thank you for joining me today. And yeah, this video will be kept in our Facebook page for I think a month, because the Facebook will delete the live sessions after a month. But you can easily get that avail that from our YouTube channel. So don't forget to subscribe there. So thank you for watching me. Thank you for watching this session. So don't forget to visit our YouTube channel and see you there. So see you on the next program. Have a nice day.